Great. Hi, everybody. How's everybody doing?
Hello.
Let's get rid of that slide. Thanks for joining us this afternoon, guys.
It's a pleasure.
Appreciate the transition. We're running simultaneous or back-to-back sessions here. So thanks for hanging on with us. So everybody, this afternoon we are talking about my favorite topic, virtual care, and how we can use it to expand access to communities across the country right now. And we have with us three incredible speakers who are doing this in their daily lives all day, every day. This is what they think about. And I'm really excited to have them here today. We've got Dr. William Lopez, who's a National Medical Director with Evernorth, who's going to be sharing with us some information about behavioral health. Hi, welcome. We have Dr. Roy Schoenberg, who is the CEO of Amwell, is doing incredible work right now expanding access. And we have the wonderful Michael Crawford here, the Associate Dean for Strategy at Howard University School of Medicine, doing all kinds of great projects all around DC, which I'm in the area and hear about constantly. So thank you to the three of you. So glad you could join us here today.
It's great to be with you.
And what I'd love to do is just start by hearing from each of you how your organizations are using virtual care and other tools to expand access. So maybe we could just kind of briefly go around and talk about it. Roy, why don't we kick off with you? Amwell's been doing really incredible things right now. Can you share maybe some data about the actual impact that your efforts have had on communities?
Well, I think, the definition of what's a vulnerable population is at the basis of this conversation, right? When we talk about telehealth and its ability to reach people where they are, vulnerable population are people that live too far from healthcare. There are people who are homebound. There are people who are not getting the right kind of healthcare. There are people who are not getting specialty care, only primary care. People who can't afford care. I mean, it goes on and on and on in terms of who do you reach. I would say that, in terms of the efforts that we are specifically investing in or spending time on along those lines, I would say are in four categories. First of all, there is the services part of, our network, where we're pouring literally an incredible amount of additional reinforcement in behavioral health. Because that seems to be an area of thirst, and I'm sure that the Bill's going to talk much more about that. But both our commercial clients on the payer side as well as on the health system side are literally trying to make anything possible available to their populations, and this is an area where we see an incredible area of growth. We're also changing our credentialing of our networks in order to allow much more Medicaid services to be delivered. We have a lot of commercial payers who are looking for it, and it's complex. CMS is not known for making things easier, never been. So we're kind of bending over backwards to make sure that our networks are eligible to deliver a lot of services in Medicaid side. On the technology front, probably the biggest areas of investment are really the home side. Understanding that there is a whole different kind of population that is going to receive telehealth in the home. The biggest distinction is these are not people who are proactively looking for someone to talk to. They're not people who are downloading an app in order to find someone in the middle of the night for urgent care. These are people that need to be cared for. That's a very different kind of profile. These are people who are bedridden, who have chronic conditions, who have difficulty getting out of their home. And we need to allow the care providers to walk in and out of that reality in the home and care for them. These are very, very vulnerable patients who we do not want to see hospitalized as the only way to care for them. And then lastly, I would say on the experience side, the biggest part, the biggest, frontier that we see evolving in front of our eyes is that when you talk about vulnerable population that cannot get healthcare otherwise, looking for technology that can be always on around those patients, that can become a regular companion day in and day out, morning and evening, interact with those patients, understand what they're challenged with, and as necessary, escalate their care into higher and more costly level of care is essentially the bucket of care automation, which I know is going to rub a lot of people the wrong way, because how could you even think about automation in healthcare, which is such a personal thing? But I actually think that that's a huge opportunity that's opening in front of our eyes. So if we're talking about titles and being brief, I would say these are the areas that we're heavily invested in.
Great, and I want to get into that area more in just a moment. We definitely want to jump into that. Michael, first, talk to us a little bit about the 1867 project at Howard. Can you explain to folks what that is and talk about how it's tackling kind of complex health challenges right now?
Well, good afternoon, everyone. And Jen, thank you for the opportunity to participate in the panel in e-health initiative. So I appreciate the opportunity to talk about this timely and meaningful topic. I am the founding executive director of 1867 Health Innovations Project. We founded 1867 this past April, so April 2020, primarily to partner with corporate partners, entrepreneurs, researchers to tackle complex challenges confronting medically underserved communities from a digital health perspective. We really focus on trying to identify the following types of technologies to pair with new and existing models of care to improve four things: access, outcomes, affordability, and most importantly, the patient experience. And we are incessantly focused on looking at and exploring sensors that passively and actively monitor, virtual, augmented, and mixed reality. Telehealth obviously is an area in which we play and explore. Wearable devices, data analytics platforms that aggregate data across disparate platforms to help inform and provide additional insights for care delivery. And then we also look at natural language processing technologies and facial and voice recognition. All areas in which we through our evaluation have noticed that these are not things that are introduced to medically underserved communities, albeit rural or urban. So we have, since our inception, we have developed partnerships with entities in the aging space to explore health and data solutions for 50 plus medically underserved. We also have looked at sickle cell disease very acutely in terms of how health and data can play a role in improving the health and well-being of sickle cell disease patients. And most recently, we have looked at low income and public housing as an opportunity to offer digital health solutions in that environment. We have two active pilots underway, primarily in the diabetes space, looking at type 2 diabetics over the age of 50 through a partnership with Howard University's Diabetes Treatment Center to look at if we have a device that has facial recognition, natural language processing, telemedicine capabilities that dispenses medication, can that help the population improve their medication adherence and hemoglobin A1C levels? Through our initial pilot, the answer is yes to all of the above, right? We improve medication adherence, overall management of diabetes, as well as folks said they would recommend it to a friend. What we noticed in this pilot is a couple things, and I think Roy touched on them around looking at the environment and social determinants of health, reason why we're having this discussion. We noticed that broadband was a huge impediment for individuals to participate in this particular trial. And so we recognize that also digital literacy and health literacy is a component where we can amplify and explore. And then the last piece, we noticed that on the provider side, that providers also need to enhance their digital literacy. It's very much like prescription medicine. Physicians and providers are not going to prescribe something that they don't have the technical competence and ability to be able to use and recommend. So we're working with folks on both sides. And then the last pilot that we're working on is an online platform where we crowdsource individuals that are type 2 diabetics to determine whether or not we can improve their medication adherence through peer-to-peer support. The data is still inconclusive, and we're still evaluating that. So I'm looking forward to seeing what that looks like online versus offline and the combined two to determine if they're efficacious. And then lastly, we are looking at conducting additional pilots in the hypertension space, behavior and mental health, also in the cancer space, in sickle cell disease, and most importantly in women's health, where we know that the infant mortality rates are abysmal, not only here in the District of Columbia, but throughout the country.
Fantastic. Thank you, Michael. Will, talk to us about behavioral. I know everybody's interested in it. This is what you do day in and day out. Can you talk about Evernorth and how you address that need?
Yeah, definitely. Jen, first of all, thank you so much for having me participate in this panel. Really appreciate the opportunity and appreciate the company today. Anyway, let me just put it in perspective. With COVID last year, we saw a significant increase in the use of virtual care, and as we all know, interestingly, we have seen a decrease in the utilization of medical services through virtual, and now our own experience in Evernorth and Cigna is that probably about 15% of visits are virtual. However, in behavioral health, we have seen a consistent and constant level of utilization. We are right now, on our own experience, around 60%, and has been through 2021 as well. In response to that and to the needs of needed communities and health equality, we have taken a broad approach and going in different areas. First of all, we have expanded our network of providers that offer virtual care. Of our total network of over 200,000 providers, about 68,000 currently provide virtual services to our customers. So we have focused on expanding our network and promoting virtual within our own network to expand that service. In addition to that, we have partnered with multiple vendors and companies that offer different digital solutions, like, for example, Ginger, MAP, Caden, Meru Health. So we have different options for our customers to access care through a digital means or virtually, especially in a time where there's so many limited resources in the way of the number of psychiatrists and social workers, psychologists that are available to provide care for our leaders' communities. So definitely we're focusing on that as well. In another area, actually, we're partnering with some of our wireless carriers so they can eliminate any data or minute limits to their plans for areas that are disadvantaged. So these customers have the opportunity to access health services without having to pay more for that. We offer discounts. Actually, we have a virtual literacy program through some providers where we offer them videos on virtual literacy for their patients, so we can educate patients on how to use technology as well. And in certain areas, we actually provide devices or help clinics to have a virtual pod, so they can have their customers access care for consultations for behavioral health or medical services. Okay. Another area that we are actively involved is partner with other organizations, like for example, the Alliance for Connected Care and the American Telemedicine Association, so we can lobby together in different areas, like, for example, promoting permanent adoption of many exceptions that were open during the period of emergency, eliminating some of the requirements for in-person visits, the use of audio-only technology, especially for mental health visits, and efforts to expand broadband and G5 to provide more people with internet access. So you can see we have a broad approach to help with inequalities in mental health care.
So this is perfect transition, because I want to jump right into these barriers, and there are a lot of barriers. I mean, some have to do with public opinion, just the direction we're going, but a lot of these are regulatory barriers in terms of a lot of waivers were made during COVID, and we want to keep those permanent, definitely. But in addition, there's regulatory barriers, state by state, federal as well. One of the biggest barriers that we hear about is, a lot of these models are designed to operate at a state level. So we know during COVID, a lot of those licensing requirements were relaxed, but certainly, patients are suffering from the inability here to reach, I guess, or go beyond state barriers. I'm wondering if we could talk about that a little bit and how we might address that. Roy, I'm going to let you jump in here first.
Sorry, the mute button never fails.
Always.
The first instinctive reaction is, yeah, who are we kidding? I mean, the fact that, we still think about state licensure as something that's impeding the use of telehealth is crazy. We need to understand that the internet does not stop at the state line border. And if anything, COVID has shown that, the different parts of the country are not affected in the same way. There are areas that have been incredibly challenged, where other areas were a little bit doing better. And if we were only able to pool together and essentially pool our resources as a nation and distribute healthcare, in a load balanced way, we would have had a much better reality. We could have saved lives. Fool me once, okay, we went to COVID. It's time for us to recognize that there are things we need to do to make sure it never happens again. And by the way, it won't happen only with COVID. It will happen with hurricanes. It will happen with fires. It will happen in urban deserts that don't have healthcare. There's 50 million ways in which we need to open it up. But the part that I just want to highlight is opening up state licensure is one dimension of it. If we continue to think of telehealth as a way to replace an office visit with a phone visit, it will be easy to argue, well, why do we need to change state licensure? It's just a different way in which the doctor sees the patient. So it's still a state business. We have to think of telehealth as an opportunity to completely redistribute healthcare. It's a way for us to reimagine how healthcare resources can be spread around the country and spread around patients, how we can collaborate with different disciplines who are coming from specialty care and tertiary medical centers versus primary care that is much more at the level of the community. And if we think about it as a redistribution mechanism, then state licensure is one of the elements that need to go away. But there's no reason why we can't think about why can't cancer institutes that are in certain parts of the country be providing support to local clinicians who are caring for patients with that complex cancer in places around the country that have absolutely nowhere near a tertiary medical center with that kind of knowledge. So when you start peeling the onion, the state licensure is the red thing that you put in front of the bull, but this is just the beginning of resolving or removing our ability to completely reimagine our healthcare experience because of these technologies.
So Michael, talk about what they've done in our area, DC, Maryland, Virginia, to address that ability to go beyond state lines. And is that something we could do federally, you think?
I think that the Interstate Compact provides a framework for us to be able to do that. DC is a member of that Interstate Compact, which allows us to participate in providing health services across different jurisdictions. Last time I looked at the numbers, 32, maybe it has increased since then. But it provides opportunities for specialists here and in other states to be able to deliver services to patients in rural or even urban areas where subspecialty care is a huge deficit. And I know that sometimes we have broad distribution of primary care, but the number of communities that I have come in contact with, not only here, but across the country, there is a great deficit and void of subspecialty care. And I think Roy mentioned cancer is an area. Psychiatry is another area. Endocrinology is another area. And then if you look at hematology, when you think about the sickle cell disease population and the distribution of these subspecialists, it's very hard to access them because they're generally in large urban centers where you can see a lot of volume. So if you live in a rural area, it's very difficult to be able to access that level of care in your community. So I think that the Interstate Compact is an example of a framework that we can build upon. I also think that we need a comprehensive telemedicine plan that not only is looked at from a Medicaid perspective, a Medicare perspective, a commercial perspective, but from a United States perspective in terms of how we can deliver telemedicine in the most comprehensive manner to especially the communities that need it the most. I just read a recent report, and I know everyone on this panel probably listening on this call about what USDA is doing now in telehealth, what FCC is doing now in telehealth. The most recent decision by CMS in terms of extending some of these waivers for a period of time. What about if that was more integrated in terms of how we were thinking about that? What about if the resources were more strategic in terms of its allocation? What type of impact would we have, not only in healthcare, but across other areas in society as well?
Will, why do you think seems to be a more accepted model in mental health and behavioral health care to go across state lines? I wonder why you think that is.
Well, I would say that, first of all, I completely agree with both Roy and Michael, very good points. Related to behavioral health or mental health, I think there's a longer precedent. There's a number of things the precedent If you go back to the late 80s, early 90s, even the VA administration was already doing virtual care for behavioral health. And back then they had these units, that carts that were huge and you have to move around, but they were doing it already. Another part of this is that actually is of all medical specialties, the one that requires the least physical contact. We basically just have to look at someone so you can see their state of mind. You don't have to have hands-on. So that really facilitates that transition. One more point that I will make is that another thing that is changing with virtual care and behavioral health is that it's really breaking the stigma, the barriers of stigma. We have seen more people accessing care for behavioral health than before. Even on our own book of business, where about 4% of our membership accessed care for behavioral health prior to COVID, we're now to around 8 to 9%. So about 40% increase total on customers accessing behavioral health services. So I think this has been a great way to break down some of the stigma about seeing a provider and having access to behavioral health.
So Roy, well, I'm going to ask you guys tough questions as the MDs on this panel. Do you think the medical boards would go for this? I mean, do you think that they would support this model? Let me just throw that softball out there to you guys.
I think the medical boards have an important role in making sure that the quality of training and the quality of conduct of clinicians is up to snuff. And I don't think that needs to go away. I think it's not a secret. Everybody knows licensure is one of the revenue streams of medical boards. And we gotta be mindful of that. And if there's a way for us to allow the medical boards to be properly funded to do what we really want them to do, and not force them to make that revenue off something that's restrictive, I think we'll be in a better place. I don't think anybody has any bad intentions. We just need to understand the cogs in the wheel, and then everything's going to be fine.
Yeah, I agree. And from my perspective, it's going to take a long time to make changes, and it may have to come from the federal level. I think that, first of all, to make permanent some of the changes that have been happening during the period of emergency, it actually is going to take an act of Congress. They're going to have to vote on that. In the meantime, we're going to have to look at short-term solutions like what Michael was talking, like expanding in the compact model so we can have more providers available to provide services across state lines. And it will be something that will be incremental, but we're going to have action at a federal level. And that's where I was mentioning that we're partnering with other groups to lobby and legislate, with legislators.
I just want to interject one more thing. We think,
no, go ahead, Roy, please.
Just a short remark. We just think that the world is going to be a better place the moment that state licensure is going to be fixed. We have to remember that, think about the Blue Cross Blue Shield structure that is state-oriented. These are different entities that are only allowed to cover patients within that jurisdiction. There is so much more that needs to change in order for this to work out. And then I just want to remind everybody that today, there is an opportunity for clinicians to consult under other clinicians, not patients, but other clinicians across state line. And that can easily be achieved through telehealth. And we're still not doing it. Maybe because clinicians sometimes don't ask for help. That's more of a people thing rather than a medical thing. But the issues are much deeper than just removing the state licensure.
Yeah.
And Jen, I just want to make just one point from a non-clinician perspective.
Please. Welcome that as well.
Two things that I think that I'm reading and interpreting from some of the legislation that is being proposed is that folks are trying to identify metrics that make sense. And how are you able to measure the efficacy of telehealth and care delivery from that modality? So I think a stakeholder conversation of the ecosystem would be beneficial in terms of what that might look like. Who leads it is TBD, but you would think that the federal government would lead that discussion. And then the other piece where I come at is from an innovation perspective. If we don't solve some of these state and geographical restrictions, it's very hard for innovators to think expansively about business models that scale. When you think about states have different rules and policies that impact your ability to craft a business model that scales. Roy knows this as a CEO. You're talking to your investors and they're asking about your business model and your ability to scale. And when you're bogged down in regulatory challenges, it's very difficult to be able to attract the funding you need to grow out an idea that potentially could be a panacea for some certain populations.
Do you guys see any hesitancy in terms of expanding virtual care to, Medicaid populations or some of these vulnerable populations? Do you think is accepted now or more accepted now because of the COVID pandemic, or do you still see some hesitancy on the part of providers?
I mean, I'll take a stab at this.
Yeah.
I think that there is definitely a common sentiment that if anything, that population is the one that could benefit the most from availability of those services. But it's not very different in terms of Medicaid and Medicare, in the sense that people are trying to get their arms around. So what's kosher, care over technology? If a clinician has a chat through a text message with a patient, is that a claimable transaction? Where does the visit start and end? It's a completely different vocabulary. There's an opportunity for incredible fraud and abuse that, of course, worries these organizations. The good news, I think, however, is that they understand that conversation needs to happen. It's not going to go away. A lot more of our healthcare experience is going to be carried out over technology, like every other part of our life. And we need to write the dictionary from scratch.
Yeah.
Mhm.
It's going to take time, but this is beginning to happen, and that's a great place to be.
Michael?
And I'll weigh in and just build on some of Roy's comments. I think telemedicine absolutely could be a way to extend access to vulnerable and medically underserved communities. But I think that certain things need to be taken into consideration, right? I think that we certainly need to look at the broadband issue, make sure that folks have a broadband speed that is acceptable to be able to engage in a telehealth encounter. The other piece is that we also need to look at these connected devices that allow us to generate more data to help our clinicians make informed decisions from a virtual health perspective. So as we look at telehealth, we need to also look at sensors and remote patient monitoring as an opportunity to have a more holistic telehealth experience. The other piece I will talk about is the digital literacy piece. And a lot of folks, while we think having a telehealth encounter is pretty seamless because there are sophisticated folks on this call, some people are very intimidated when it comes to using the internet. Some of the folks that participate in our pilot were digital naive and they were 70 years old. So can you imagine you're at 70 years old and this is the first time that you've had a meaningful encounter with the internet, and it was prompted by the pandemic, that you had to receive this encounter because your care otherwise would have been delayed. You wouldn't have been able to refill a prescription. So I really think that we, one, need to ensure that folks have access. Two, we need to equip them with the skill sets to be able to engage in this process effectively. And then three, we need to make sure they have the confidence and feel empowered to be able to have these conversations with their clinicians. And the last thing that I would mention is that we all know that the future of healthcare is really about self-management. With wearable devices, with telemedicine, with sensors, connected devices, IoT, et cetera, that we pretty soon will be managing our own health, right? And then having really informed discussions with our providers. And if we don't address some of these health equity challenges, you will have more communities that are left behind, disparities will be amplified, and other communities will continue to share the highest burden of chronic disease.
We'll talk about some of the digital health literacy issues you have in the behavioral health setting.
Yep. So, we have a number of areas where we have a struggle. One of them, especially minority groups, is with translation services. So we have had to enhance services and offer actually to network providers the ability to access some enhanced service translation services online, so we can support those populations. And then the other piece that I mentioned before is just trying to have devices available for customers and create these clinical pods where you can have a consultation at a pod for customers that may have mental health issues in your practice. So those are some of the things that we're doing around literacy and trying to support that.
Michael, you definitely have a Howard contingency here supporting you in the chat box. So just want to make you aware of that. Talk a little bit about some of the things that you've done in the project and around your community to really address some of these barriers, particularly, you know, the broadband issue and some of the other digital gaps.
So I think with William, he talked about how they're working with ISPs. We're working with ISPs as well, particularly as we look at deploying sophisticated solutions within these environments. So we're working with ISPs to make sure that broadband is not a barrier to use technology. We're working with different entrepreneurs and manufacturers to introduce technologies that align with our innovation priorities, which is around primarily chronic disease management in underserved communities. So we're also looking at the education component. We also recognize on a provider side and in an academic and training side that we need to expose our students as well as our faculty to these types of technologies as early as often as possible. So our students are participating in these clinical pilots. They're being led by our faculty members who are the PIs on these projects. And then we're also working with our administrative staff to be able to make sure that we're providing the requisite technical support to make sure that people are properly onboarded and offboarded from the technology, which we have found to be a challenge with some of our clinical pilots. If we don't get the onboarding right, we see that there is some atrophy in terms of the pilots. Folks start to trail off because they've had a negative experience. There's a lot of friction and pain points. And we are using these insights not only to help inform new care delivery models, but also helping with our manufacturers to create more inclusive products that can be offered to a broader set of individuals and communities, which ultimately is a good business.
Roy, one thing I want you to expand upon is something you mentioned earlier about the ability to use virtual care to really expand geographic boundaries. So, you know, having a provider with knowledge help someone with a unique cancer condition in the Midwest. Can you talk about that a little bit? How often is that happening? And if it's not, why not?
Well, I think it's happening in some places. I think there is, there's like sentinel programs where organizations that have very, very reputable knowledge in certain areas like Cleveland Clinic and cardiovascular and, Memorial Sloan Kettering and some others are saying, we're going to take the knowledge that we have that represents the cutting edge of what we know actually works to treat patients, and we're going to make it available to a broader population of not only patients, but also other clinicians. And that in itself, just that little subtlety of the notion of distribution of knowledge could have profound effects on the quality of care that we can see in a lot of areas around the country, if you're talking about vulnerability from a geographical standpoint. We're always familiar with all of these studies that talk about geographical variation of healthcare. National Library of Medicine had a lot of that, and others. If we were able to literally just make the knowledge that we have in this country accessible to wherever it's needed, we would have a completely different kind of healthcare. And I think that, funnily enough, the brokering of how to get clinicians in front of the other clinicians that have that knowledge is actually fairly straightforward. We know where the knowledge centers are, we know what the rules of engagement are, and it's actually very easy to make the financial calculation of what happens when you properly treat a cancer patient rather than improperly, right? I mean, it's an arm and a leg for the mistakes that we're making. I think the challenge that we have is that we don't have leadership. It comes down to leadership. We don't have leadership that has the willpower to invest in such a strategic change, because usually that change is going to take more than one election cycle. I'm sorry for being blunt here, but that is what it takes. And, at the end of the day, we talk about vulnerable population. We think about people who are poor, people who are sick and everything else. We're all going to be a vulnerable population in 20 or 30 years. We're all going to be elders, and that makes us vulnerable. And I hope that the conversation that we're having today is going to allow us to expect a much better healthcare reality when we're old and we want to stay home and allow the healthcare that we need to come and surround us where we want to be, which is really the opportunity that's in front of us right now. But it comes down to leadership. It's not technology. It's not even the money. That's it.
I mean, Will, we saw through the pandemic, behavioral health was something, very hard to get appointments for a lot of folks. We've seen depression and anxiety rates skyrocket over the last year or so. Virtual care could really help address some of these access issues for patients. Do you think that that's happening right now? Or if not, how could it happen better?
Yeah, I think it's happening to some extent, but in line with what Roy and Michael are saying, there's had to be a change across the whole healthcare delivery system, going from how we train our residents. I mean, like, Roy, I'm sure that you didn't take a course on virtual care when you were in medical school. I didn't. So we have to start from the fundamentals. It goes from there to what Roy said, leadership as well. So I think we're seeing where virtual has open access to behavioral health. I think that we probably need to see more of that happening. But there's a lot of work to do in the behavioral health space. As I mentioned, the adoption by provider has been a lot better or higher than for medical doctors. But on the medical side, on the other side, they're still trying to figure out how they're going to be able to continue supporting virtual care. For many providers, it's a challenge because they need to wrap their brain around how do I then substitute some of my revenue streams like labs. If I have a patient come to the office, I can have them, we need to do some blood work. Where if they don't do virtual, if they say virtual, that's not going to happen. They're not going to do x-rays. So they're going to have to kind of be more creative on how to develop alternative revenue sources or how to partner with other groups to do that. So I think that in that respect, we're ahead on behavioral health, but there's a lot of work to do for general medical services.
And
Michael, yeah, tell us about any innovative techniques that you guys are using.
Well, one thing I just wanted to build on the leadership piece, and it extends beyond election cycles. I think what this healthcare event, this pandemic has showed us is that telehealth needs to be embedded in our emergency preparedness, right? So even as we think about emergency preparedness differently, we know that telehealth, broadband, digital skill sets need to be embedded in emergency preparedness plan to deal with the next health event, the next hurricane, the next extension. So I think right now is an opportunity for us to say, hey, we want to reimagine our emergency preparedness. We want to make sure that our communities are resilient wherever they reside throughout the country. And one of the things that will make them resilient is everyone having the capability to access the internet. Telehealth is built into those models, and then everyone has the skills to engage in that process. So I am wholeheartedly advocating for a way in which we can build more resilient communities, underpinned by technology and access to broadband. So, and I think that every time I have an opportunity to talk to folks, particularly at the federal government, I talk to them about building more resilient communities that are oriented around technology that can facilitate a better and amplified healthcare experience.
That's a really great point around emergency preparedness. Excellent. We could do a whole session on that. I think it's a great area to jump into. One thing, so we spent a little bit of time hinting about the money. Can we talk about the incentives a little bit? And there's another incentive program that was very popular and then not so popular and then popular again, meaningful use. Ring a bell, folks. So what about the thought of doing some kind of, or CMS having some sort of financial incentive program to, make some of these transitions to virtual care more, accessible or manageable for providers? Will, you mentioned, the whole idea of, they don't want to lose revenue. If we go virtual, we'll lose the lab fees, whatever it might be. What do you think about the appetite for some sort of incentive program, federal incentive program?
Yeah, I think that in the current environment and from what we know about CMS, I think the appetite is low. I think that there's still a lot from that, from the government perspective, federal government, there's still a lot of fear about fraud and abuse. So I think that it's going to take some time for them to get more comfortable. I mean, even from things that we have known for years that are absolute, like having an originating site, having different, like a patient has to be in a clinic to be able to access care. I mean, those things that we have not done in commercial for years anymore. So from that just changed recently. So to get to the point where they're going to pay an incentive or provide incentive for turn to virtual, I don't see it happening in the immediate future. I mean, I think that would be great, but I think there's a lot of concerns, which to some extent is valid, related to fraud and abuse.
Roy?
Yeah, I think we should jump into this, right now, because, and obviously I'm biased, I admit, but the reality is, if we understand that the delivery of healthcare will be a balance between digital and physical, and to some degree automation that will come into the play, making sure that our healthcare community speaks the language, rather than we walk into a Tower of Babylon of 10 years or 15 years of people not sure what to do, yes or no, whatever it is. Yeah. Ambiguity doesn't help. And just like at some point, following the very famous publication about, medical errors in medicine, there was a decision at the federal level to say, we're going to encourage every healthcare institution to put an EHR in. And that was meaningful use, right? That was the tax incentives for implementing an EHR. Telehealth and digital care delivery is going to be a foundational infrastructure for our ability to reimagine healthcare. If we're stubborn, if we are going to have a confused voice around it for the next 15 years, it will hurt all of us. So this is one of those cases where, just like the interstate highway, is a federal program, to me, a meaningful use equivalent of saying, let's make sure that healthcare organizations are fluent in delivery of healthcare over technology, is the exact thing that we need to do today.
Michael?
What I hear Roy saying is that telemedicine is a critical infrastructure, right? So if you look at how Homeland Security looks at critical infrastructure, it is a critical infrastructure. I think that there's are elements of meaningful use that make sense in terms of us being able to look at how do we incent adoption of virtual health solutions and tools. I think that right now, with this transition from from fee-for-service to value-based, is a great opportunity for us to think about how technology complements value-based and total cost of care models, right? Particularly those areas that cost a significant amount in the cancer space, kidney care. Those are opportunities for us to think about new models of care supported by technology, including telehealth, sensors, wearables, et cetera. And what does that look like from a model perspective? And does that give the provider the opportunity and flexibility to be able to craft interventions that they think can help improve the health and well-being of their population by using technology? So I think we're at a great moment as we think about and reimagine how we deliver healthcare from a care delivery perspective, to think about how technology and telehealth fit into these new models of care.
And Jen, if I think we're encouraged to say things that are a little bit kind of, edgy, because it makes everybody, it's more interesting and it keeps everybody awake during the panel. So I think here's the thing, we're a little bit kind of falling into the trap of being very, very paternalistic in healthcare. If you think about the meaningful use, about embracing EHR and everything else, yeah, it's a remarkable, value to make sure that everything is documented and standardized and all that kind of stuff. If you ask the people that actually experience healthcare, patients, how did your healthcare experience change with the arrival of EHRs? I think you're going to find a lot of people blinking hard and saying, I'm not sure what you're asking. Whereas if you ask people how their healthcare changed because they could talk to their physicians regularly from home and get the right titration for their insulin or medications or whatever it is without having to schlep for 50 miles and so on, I think you're going to find a lot of people understanding what you're asking. How cuckoo are we that we put meaningful use for things that actually don't make a difference to a patient? And I'm fully aware that EHRs make a huge difference in quality, but we're not even considering it for something that can make such a huge impact to our entire healthcare experience.
That's a
Just
really
want to pose that question.
great point. I love that. Michael, Will, you want to comment?
Oh, I completely agree. I mean, at the end of the day, we need to look at what is going to impact our customers and what their experience is. So definitely, we're moving to an era where it's all about customizing care for our patients. And like Michael was saying, it's just going to be us controlling the patient, the person controlling their own health care with devices or connectivity. So completely agree.
I concur with that. And I think that the more that we amplify education in this space, I think the more that patients will be able to recognize the benefits of the technologies that they're able to access. And I think that with absent that education, I don't know if folks will be able to understand the benefits of the technology that they're being able to use. So if we continue to educate them, empower them, and they're engaging more, they will realize and understand the benefits of being able to use these solutions.
I love that. And yeah.
Something that comes to mind as we're talking about this topic and CMS and how they're going to act, I think the changes in the next few decades will may influence what they may do or not do. If you think about the baby boomers coming into the Medicare environment, we're talking about a different population with different set of expectations. These are people who are going to be employed longer, having more demands on what they get from Medicare. So there may be an element of influence on the population that CMS have to serve and to meet those demands, because it's going to be a different group from what we have now in Medicare.
Yeah. So Roy, we've got about 30
You're actually
seconds
just right. Yeah, just right
Yeah,
at time.
30 seconds left, Roy. So any last final comments? I'll give you the last word here.
I think we need to stop thinking of telehealth as the phone company. And I would just say, think about what FedEx has done to retail. Telehealth is the FedEx for healthcare.
Love it. And I want to thank all of my panelists today. You guys have been fantastic. I think this has been the best session. Thank you so much. And
thank you all. Thank you.
Appreciate your help today. All right. So you guys have a great day.
Bye.
Thanks, everyone.
Bye, guys.